Welcome to Behind the Citgo, where we pull back the curtain on the unseen truth of addiction recovery and talk about things most people never get a chance to see. I'm your host, Josh Torbich. Each week, we're sitting down with people who lived it, led it, and are still learning from it today. This isn't polished, it's real, it's raw, and it's noted in the faith and hope because we do recover. So whether you're in recovery, walking alongside someone who is, or just trying to understand what healing really looks like, you came to the right place. Let's dig in. Hey, what's up, everyone? Welcome back to another episode of Behind the Citgo. I'm really excited for today's session. Bear with us. It's our first digital interview that we're doing. I knew that Dr. McCance-Katz was going to be hard to get here in person. I didn't want to try to fit into her in-person schedule because I'm really excited about this chat today. But here we are today with Dr. McCance-Katz, and we're so happy that you joined us today and that you get to be a part of this conversation with us.
Thank you. Happy to be here.
Let me tell the folks a little bit more about you before we get started, but we know you're an actual doctor. So the doctor's not just a PhD, right? So you're an actual doctor, and you've been doing addiction and mental health for over the past 30 years as a priority of your focus. And interestingly enough, one of the cooler things about your previous career, especially recently, you were the first assistant secretary for the mental health and substance use disorder at the Fed level, right? So that was for the executive branch.
Right. Mhm.
Yeah. So very excited to bring in your perspective today about one of the more trending topics of what we get to interact with. And the title of today's episode, I think a lot of people are going to be interested in. But the title that we drummed up with was When Harm Reduction Causes More Harm. And I know that there's a lot of dialogue that takes place, especially inside of our facilities and other recovery programs across the state, about where that line for harm reduction is. But I thought it would be a great benefit to the folks first to hear directly from you. Can you describe harm reduction for all the folks who are listening to us today?
Sure. So harm reduction is it's an approach that basically tries to minimize any negative effects that might happen to a person who is a drug or alcohol user in terms of social issues, legal problems, health problems. Um, But it does that from the perspective of rather than advocating that someone enter treatment, which, by the way, in my opinion, is the best way to minimize the negative effects of substance abuse. But it kind of tries to meet people where they are, is what they say. And what that means is people don't have to want to get help in the terms of treatment for their drug use problem. And harm reduction interventions will try to help people to be able to safely continue their drug use, with the idea being that at some point the person may make a decision to enter treatment. But if they never did that, that would be okay too. The harm reductionists would just keep wanting to provide services and resources to people to allow them to continue their their drug use. And they would, I think they would argue that it's the drug use shouldn't be stigmatized, that it's a lifestyle choice that people make, and that we should do what we can to minimize any harms from that. The problem is that approach and the kinds of things that are offered by harm reduction programs can, in themselves, be quite harmful. So, what I mean by that is that there are a number of approaches to harm reduction, and I should start by saying I don't think harm reduction is a bad thing. I just would define it differently than harm reduction is defined right now, and the programs that support harm reduction would define their services. In my
Yeah,
own
before
view,
you get into that, would you share with the folks some of those? So I know you're an expert around what they currently look like, especially over the past 5 years. What are some of those, before you get into that, what are some of those services right now that we see over the past 5 years in harm reduction?
Yeah. So probably the one that there's a couple that are really visible to the public. One is um, syringe programs, syringe distribution programs, which do more than distribute syringes. That's one. Another, and what's grown out of syringe programs is um, is something called safe consumption sites. So these are places that are set up in various communities that have somebody present who could possibly reverse an overdose if that were to happen while somebody was using a drug at their site. Um, those are not legal in the United States, but there are a number of these programs around. And in the state of Rhode Island, which is where I happen to live, they've passed a state law, and they do have these programs available to drug users. So that's two different programs. Another is the use of fentanyl test strips. So telling people that they can make their drug use safer by putting a little bit of water with the drug and testing it to see if fentanyl is present, which may or may not work depending on how a person does it and depending on what part of the drug they test. Um, so fentanyl test strips, and another one that maybe people sometimes don't think about as harm reduction, but decriminalization efforts. And so what I mean by that is in most places, open use, open injection and use of drugs in the public is not allowed. But there was a big um, um, project in the state of Oregon where they decriminalized drug use, and that went on for a couple of years, and it got so bad with their downtown areas really turning into just open air drug markets and people using drugs openly that their people actually repealed that law. So so decriminalization is another. Naloxone, over for overdose reversal is a harm reduction intervention, and then educating people about safe drug use. So using with others, having naloxone present when they're using, maybe using the drug more slowly than they might otherwise. Um, Another harm reduction intervention is the type of syringes that one gets when you go to a syringe exchange program. And there are a couple of types of syringes. The ones that we use in the healthcare system are ones that after you use the syringe to inject whatever medication was given to a patient, it will kind of self cap, so it makes it safe, and people won't be at risk for getting stuck by that needle. In the syringe exchange programs, they don't do that because they think that people that are using drugs need to be able to manipulate that syringe to alter the amount of drug they're using, maybe the rate at which they're using, which is harder to do when you have a syringe that self caps. So they actually distribute syringes that are quite dangerous because they're often thrown into the street, and this is a risk for other people, children, animals that might come in contact with just syringes that could have all sorts of infectious agents in them that would present a real risk. So that's just kind of a broad overview of what
Yeah,
the different harm reduction interventions are right now.
one of the interesting things that I really want to pick up on for the audience, because we know this, but zero in on how it's illegal for a safe injection site to exist at this level. And now some states are actively approving laws to make them exist inside of their communities. Can you touch on that a little bit and how that's even possible?
Well, it's a little complicated, but it's basically this. There's a federal law called the Controlled Substances Act. Controlled Substances Act says that you cannot facilitate, distribute, um, use drugs in an area if they are illicit drugs. That's been the law since the 1970s. But in recent years, some of the harm reduction activist groups have pushed for these safe consumption sites. And I should say safe consumption sites because they don't just have people that are going to use drugs by injection. They are called safe consumption sites because you can come in there and you can smoke your drug or you can use the drug nasally. Basically, however the person prefers to use drugs, these sites are set up to facilitate that use. And how is it legal? I mean, basically, it's not legal. But when you have a federal administration, such as the previous administration that we had, they supported those kinds of efforts, basically, in that while they didn't seek to change the federal law, they kind of turned their heads to the expansion of these kinds of sites. In states that are very liberal in terms of how they view things like the use of substances, this is a signal that they can go ahead and put these sites in place. And so that's what happened in Rhode Island. Now,
Yeah, it's
there's
very
also
interesting.
there's also an ongoing court case in Philadelphia, in Pennsylvania, which has been
Yeah.
trying to open one of these sites for years, but the federal government has said no. And that started back in the first administration of President Trump. And that has been bogged down in the courts, and it still is not a site that's open.
Wow. Yeah, see, that's all very interesting. I knew about the site in Philadelphia that's been under that back and forth legally for years now, and that's a very interesting thing to trend with. And we'll put a link in this description for anyone who wants to read more about this. So, all of these programs getting this major push to open up, there must be some compelling evidence around harm reduction and how it works and the different things for it to be considered what the coin term now is evidence based over the past few years. What are
Mm.
what are your thoughts around that?
Well, my thoughts are that if there's an evidence base, um, it's not that strong. And what I mean by that is, I go to websites. You can go to Harm Reduction International. You can go to Safe Support, and they will talk about many years of research being done and data that shows that these are uh, practices that are helpful to people, but they don't put any references in there, so you don't know exactly what they're talking about. And sometimes, if you go to AI and look it up, you'll get, I don't know, something from one of these websites. You don't get a lot of scientific papers. So, so I think that there is some literature, but I also question how these studies are designed, the bias that goes into putting surveys together, for example, the kinds of things that authors of papers are allowed to say when they have produced no evidence in their article of what they're claiming. Um, you know, it's an area that is supported by a number of people who have a lot of power in the media and within communications within our country and within academic settings and within government more recently. And when you have those things come together, then you get a big push for these kinds of interventions.
Yeah, so one of the things that we understand, often is that people will tout this as their most compelling argument whenever it comes to harm reduction efforts is, it's saving lives. And there is obviously it's hard to it's hard to even have a conversation when you go past that place is like, well, it keeps people alive, and that's true. And there's many components of harm reduction from my perspective that are great in that avenue. But there are also some ways where it quelches the ability for people to live their life. to the fullest extent. So is that getting to a place, where we're understanding that this is harm that we've kind of inherently adopted through these harm reduction programs?
Oh, I think it's going to be very difficult to make the case that these harm reduction programs are actually harmful. Um, just because we've had a change at the federal level doesn't mean that these things are going to go away. They will not, and the media will not drop this, and they will continue to give very positive press to people that espouse these views, and sort of in different ways they can be negative about the current treatment system, and so that sets up a situation where these harm reduction interventions get perpetuated. But I think
Yes.
that you can look at a couple of pieces of data that don't even have to be in research about harm reduction. If you just look at, I mean, I would make this argument, and people could agree or disagree with me. But in 2019, when we looked at the National Survey on Drug Use and Health, which is a yearly survey done by the Substance Abuse and Mental Health Services Administration that goes out to about 68,000 people at random in this country and asks them about mental health issues and about substance issues. In 2019, we had 19.3 million people that met criteria for substance use disorders. In 2024, we had 48.4 million people. Doesn't sound to me like harm reduction has really been pushed, as you know, over the last 4 years.
Yes.
It's been around for longer, but it's really been pushed for the last 4 years. That doesn't sound like a big success to me. If you looked at, in 2019, we had 1.6 million people with opioid use disorders. In 2024, we had 4.8 million. So we tripled the number of people. I mean, that just doesn't sound like success
Wow.
to me.
Wow.
If you look at the number of people who died of opioid overdoses, you would see that in 2019, we had a total number of about 70,000 that died of drug overdoses, and over 36,000 of them, very unfortunately, were opioid overdose deaths. If you look at 2023, we had over 105,000 deaths from drug overdoses, and over 79,000 of those were from opioids.
Wow.
So again, I would just say, if you look at the data, which I don't see happening on in any serious kind of way when people espousing harm reduction are interviewed. But if you look at the data, I would say that while you can't assume that all of these deaths are related to harm reduction. I'm not trying to say that, but what I'm trying to say is that the push towards harm reduction does not appear to have made a positive impact.
So it's interesting that you're bringing us to all of this data, because let's not just talk about how many people have kind of turned their attention to the harm reduction efforts, but the billions of dollars that we've invested over the past 5 years. And what you're really showing us through these points that you just flushed out is that the needle's not moving the opposite direction. It's not moving back to the place that we wanted it to. So we're doubling down right now and continuing to try to see if these same scenarios lead us back to a healthier place, and it's just not happening for us.
Right. Well, if you look at 2024, um, CDC is telling us that has been a significant decrease in overdose deaths. But there's something that happened in 2024 that I think is responsible for a lot of that. And that is that with the election year being 2024 and concern about the border was tightened up. And so we had a decrease in the amount of illicit drugs getting into the country. I think that probably is a bigger explanation for the reduction in overdose deaths than these harm reduction activities.
Wow.
But I think I mean, one of the things I really wanted to say is that there's more to the harm reduction than what happens to the individual. These sites, particularly syringe exchange programs, give out uh, syringes that can be dangerous when they're discarded. And one thing that I pretty much have uniformly seen on harm reduction websites is that there isn't an increase in trash and garbage in the area that's contaminated with syringes around these sites. That's just not true. I mean, it's simply not true. And I can tell you that because I lived in San Francisco. And I can tell you that because I went to Skid Row in Los Angeles, and there were discarded syringes everywhere in the street. And I could even send you a reference from an article in the LA Times that talks about the need to have to clean the streets every day. There are so many discarded syringes. So that's just not true. That information is false. And they say that there's not an increase in crime. That is absurd on its face. When you make it easier for people to use drugs, um, you're going to have more people do that. Well, these drugs are not free. I don't think drug dealers are doing any kind of charity. So you've got to get a lot of money to support your habit. And it's just silly to say that not encouraging people to go into treatment, but rather supporting their habit it just makes no sense, and it simply isn't true.
It's
So,
to me, it almost feels like we're aiming too low. Like the way that we've positioned ourselves for a lot of this, it seems like in a lot of these efforts, we've lost sight on what actual well-being looks like. Do you see that at all?
what I see is um, is just a total focus on the person who is the drug user. Every drug user has a family, and there's a lot more harm to drug use than simply the harm that can come to the person that's the drug user. Um, it's something that I think is not talked about virtually at all, and it should be, because I also see families as the main support for people that are drug users. So I see these kinds of harm reduction interventions as harmful to communities in terms of crime, in terms of trash that is actually dangerous to the health of others, and just to the environment. I mean, everybody has a right to enjoy their communities. Nobody should have to be in an open air drug market because the government doesn't want to tell people that this is not the best behavior, and you need to take that somewhere else. I think that there's just been this change. I think one of the reasons we've seen this doubling of people with substance use disorders is because we've seen such a liberalization of what's acceptable. And what's acceptable is that a certain group that, no question, has very serious um, health issues has a lot done to help them perpetuate what is a drug using lifestyle that kills people. And the rest of the community and their families are tossed to the side. There doesn't seem to be any concern about that. One of the things that I think is really important is that, and I think that as treatment facilities, I hope you guys will do this, and I just wish all treatment facilities would do. We have to get out there and say these reduction interventions are harmful. When you come to treatment, treatment is harm reduction. Come to treatment where you can get support, where we can help you to get off of these deadly substances, where we can work with you and your family and help you to get back into your community, get into a productive life, get a job, All of those things are the focus of treatment. When I look at some of these harm reduction sites, I was looking at one before this podcast, and they were saying, "We accept you where you are," unlike treatment facilities that are abstinence-based and will tell you just say no. And my response to that is, as a doctor who has been doing this for over 30 years, is the last time I heard just say no was during the Reagan administration. That is not the way treatment facilities are set up. What these harm reduction places do is they stigmatize treatment. And then they complain that drug users are stigmatized if they go to treatment. It's I don't know. It's really it's an unfortunate place we've gotten to in this country, and I think that those of us who work on trying to save lives and do it through the treatment system, and we're always trying to improve our treatments and to improve what we do that's evidence-based, needs to be talked about more. We need to be able to talk about that in a way that is not dismissed and diminished by people in other settings.
Yeah, there's a space that you have to get to in these conversations with people where they truly start to understand the unintended consequences of what happens to a community when you normalize use of illicit drugs and abuse of alcohol. And that message, you're saying it really well, Dr. McCance-Katz, and we see this on our level often. That message gets lost in the compassion sense of this phrase, meeting people where they are. And there's a concept that Christ and a lot of the other folks, obviously we're a faith-based ministry, so a lot of this messaging comes out in us, is that it's okay to meet people where they are with the intent that you don't leave them where you found them.
Exactly.
But there's
Exactly.
a lot of this where the harm reduction aspect, while people would say, and maybe this is a place that you would say as well, that it is a great tool in some of the offerings, not some of the other offerings, but in some of the offerings, to where you can actively engage with people and meet them, in a place that they feel like they can actually connect with a treatment option, but they can't stay there. When it becomes the only option that's offered just because they're not willing to make a move onto something else, it does allow people to become complacent and comfortable in a space that they were never meant to live.
Yes. Yes. And I think that the harm reductionists have kind of um, they've kind of taken over the compassion area. And I think
Yeah.
that as treatment providers, we need to take that back. It's not compassionate to perpetuate drug abuse. I mean, if you just take it out further, when you tell somebody, "We're gonna accept you in your continuing drug use," what does that mean? So, they use the drug, a few hours later, they're starting to feel some withdrawal. They've got to get more drug, they've got to use more drug, and as they're doing this, they're putting their health at risk. Um, by the way, there's more infectious diseases than just hepatitis and HIV. A lot of very serious injuries that I've seen over the years are people who get abscesses where they inject, people who develop cellulitis. Those are life-threatening illnesses, and that is part and parcel of continuing a drug-abusing lifestyle. There are diseases such as infection of heart valves, endocarditis. Again, these are diseases that kill people. There are more ways to die from drug use than just by overdose or by infectious disease. And
And
another
you just named a lot of things that treatments aren't readily available for, but now, in our society, hepatitis C is a curable, to I think a 96%. So even some of these things might be, where they focus to say we're going to reduce the spread of hepatitis C. Well, now we have a medication that's been scholarship to many of our folks with like a 96% cure rate. And a lot of the things that you just said, there is nothing that exists, to cure a lot of the illnesses that you just listed off. Is that fair?
You can cure them, but so for example, it would take replacing a valve in your heart. It takes hospitalization to treat an abscess or cellulitis. But you bring up you asked about data. I'm gonna tell you some more data. So there was a study that was published a couple of years ago. Um, this was a study that looked at syringe exchange programs in the United States. So it looked at counties in the United States that had syringe exchange programs, and it looked at counties in the United States that did not have syringe exchange. And here's what they found. In counties that had syringe exchange, they had lower rates of HIV and lower rates of viral hepatitis, but they had higher rates of drug overdose deaths than counties that did not have syringe exchange. I would suggest that both HIV and viral hepatitis are very treatable diseases now. I originally got into the research that I've done on medications to treat opioid addiction because I was looking at people that had HIV, and it was very difficult for us to treat these folks with methadone and other medications because of drug interactions. Syringe exchange programs originally got started because we had no treatments for HIV. And we knew that the use of syringe by multiple people, if somebody was infected, they would infect everybody that used that syringe. And so these syringe exchange programs were set up with a good intention, and they worked. So even now, you will see reduced rates of infectious diseases. But if you see higher rates of drug overdose, is that really a good thing? And so what I would say is this: we can treat HIV now. We couldn't back in the 90s when the syringe exchange first got going. We have what's called direct acting antivirals, medications people can take that will cure hepatitis C. If you take a drug with fentanyl in it, then you are at risk for overdose and dying, and we're not fixing that. And so
but it's still a major that's still a major focus point for a lot of folks in the harm reduction programs, that we're preventing these. And the attachment idea is they're incurable illnesses, where what you're alluding to is that point they're not anymore.
Well, I'll tell you something. We don't see many people dying of what we call opportunistic infections, the infections that happen when you have HIV and your immune system gets wiped out. That doesn't happen much anymore because people can be treated for HIV, and they're not nearly as infectious as they used to be because the medications that they're treated with can knock down that virus in the bloodstream. And so my point is, you have to look at what the epidemiology of any illness is and see whether the interventions you're using still make sense. And I would suggest that syringe exchange in the age of fentanyl and other types of opioids that are so incredibly potent and fatal in tiny amounts make it so that syringe exchange needs to be questioned as an intervention. Now,
So you
I would
touched on. Oh, go ahead. Yeah,
I
please.
was just going to say that I am not against the use of sterile syringes, even by drug users who may relapse, but they must, in my opinion, they should be in treatment where we can work with them around those issues, not
See, I want.
these places that just hand out syringes.
Yeah, I understand. And that's a great comment. I see you touched on this place that I want to bring you back to, because I feel like it's really important. We had talked about what compassion looks like. And I want to drop a term on you. Okay. If you don't like it, you can slap me around and say, Josh, don't you use that. But there is this concept that I've introduced to my staff, and it's called toxic empathy. And I read a write up on this, and I actually read a book about what this looks like. And it's how people leverage you to descriptively change what you would consider values based off of calling it a lack of compassion. or you're not being as empathetic as you should be. We should help these people, treat these people. Now, I do have the benefit, this about me, Dr. McCance-Katz. I used to smoke crack behind a Citgo, right? Okay, so I do have that. I do have that benefit of coming from the world of an active heroin abuser. I was intravenously addicted to heroin prior to graduating high school. I didn't come in the school field to where it was a lot of fentanyl. I got sober in 2012, so it was right before the fentanyl presence really started ramping up. But there's this thing that I know was a lot less prevalent, and it was this toxic empathy to where we almost guilted people. And programs like mine are at the core of this, the focal point for when we're more abstinence based. Now, just to recap for the audience, we do have that treatment program that you actually very graciously helped us, coached us to formulate what we've been able to create here. And that's a long-term recovery and reentry program that's buttoned up on the front end with a formal clinical treatment that has an active titration program built for medications for opioid use disorder. So people are actively coming in, going through some sort of formal social setting detox where it's relevant. They have great access to mental health needs, but with the expectation that they titrate off of those drugs for detox purposes before they enter into phase one of our program. So about 4 to 6 weeks. Um, so, you could call that, maybe you would call this middle ground. Like we said, hey, this drug does have a great purpose. It helps alleviate withdrawal, makes treatment recovery a lot more attractive for a lot of people. But this is not a drug that we believe that most people have to remain on, that the majority of people have to remain on for a long term, because there's recovery and reentry services that are readily available. So the toxic empathy piece says, well, you've taken away their choice. You say, you're not allowing them to choose how they want to approach it. Have you heard that before?
Not specifically in that way, but certainly those kinds of arguments being made about treatment, um, being regimented, being one size fits all, and of course that's not the case. There are lots of ways to get treatment. The way that y'all offer treatment is going to work for some people, and other people are going to choose different directions. Um, I'll just go out on a limb and guess that you don't discourage people if they want to do that. You probably provide them a referral to a doctor or to a program that can do that, and that's the way the system is supposed to work. So how have you taken anything from them? What I think is toxic about some of the empathy towards drug users is that there's not consideration of the person's entire life. It's not just about drug use. What has happened is drug use is now consuming them, but these are people who are, in my opinion, pretty much everybody I've met, and it's been a real privilege to work with people that recover from these very serious drug and alcohol problems. They're good people. Good people with bad problems is how I've described them. But these people that are so empathic and compassionate and think that the answer is to perpetuate the drug abusing lifestyle, to me, are very dismissive of the value of that person. What about that person's ability to contribute to the community? What about their ability to have a family? What about their right to enjoy life in the community? Um, to not consider the full picture of what a person's life is worth and valued at, to me, that's toxic. And that is what I see in these programs that that talk about treatment as a regimented approach that shouldn't be forced on anyone. No one's forcing anybody, and they don't seem to really know anything about treatment, in my opinion. And so they denigrate it when they elevate ongoing substance use. To me, that's just it makes no sense. Makes no sense at all. And yet that's what's happened in our country. We have to take it back. And I think we have to take it back as treatment providers, as community members, as family members, because we love these people and we want them in our lives.
Yeah, the choice thing, and you started to dabble in this comment that I was holding in my back pocket for us. Because when we see, and we've grown significantly over the years. We locally here have about 215 beds, but overall we have about 250 beds in the state of North Carolina residentially. And what we see is that when people come to us, they're choosing the person they wish to become that's down there. And to me, when we're talking about choice, Dr. McCance-Katz, I don't really get to choose a lot of what the day is going to do to me. I get to choose some, but we've all had the Monday morning when you're running a company, and then Monday comes for you type of thing. Just the unexpected happens. And the same thing's true with the folks that we serve inside of these programs who are struggling with substance use disorder. The concept is, no, you might not be able to choose a lot about what comes for you today or the spot that you've got yourself into and how long it's going to take to wrestle out of that. But you see that person way down there that you can get to in a couple years, you do get to choose what that person looks like. And what we found is that there's so many people who come to us and say, "Wow, that person down there looks really good." To me, that is the choice. That is the greatest gift you can let someone choose, is who they want to aspire to become. And in our program, we get to say, "Okay, we're gonna partner with you to make that person come to be." And it's gonna be hard and it's gonna be difficult and you're gonna go through some struggles, but don't forget we're partnering on a plan to get you to be able to aspire to your potential. And that is somewhere along the lines, I'm not going to say that philosophy is combative to empathy, but it definitely invites more struggle than most people would like to willingly choose to enter into. The struggle of recovery is almost what gets people well, that it feels like we're trying to soften in a lot of ways with some of the programs.
Exactly. Yeah. Yeah. So, I feel like as treatment providers and as family members. So for me, I'm a family member. There's my family's been greatly affected by alcohol and other drugs. And just as a family member, I just feel very strongly. I want the people that I care about to be able to get help. I don't feel that telling them that you'll help them to not overdose and die, and you'll help them to continue to safely use their drugs until they reach a point where they make a decision to enter treatment. I don't think the people in my family, they didn't have that much time. They would be dead. Um, I have actually pretty strong feelings about this particular topic.
So because a lot of your work, and this is the last piece of the chat that I really wanted us to have, but there is policy that's always circulating around this. And your influence has obviously carried you into many rooms where you've spoken to this on a level that, I could only dream of. It's more than just the conversation of what we're having today, but your experience and your career life has brought you in to these spaces to formally discuss how this is supposed to look and what the best practice would look like. Can you frame up in a nutshell the balance between meeting someone where they are in harm reduction type model, but then also encouraging that there's this thing that we have to get them to that they can achieve? Can you help us get there and like what it would look like?
So I think that what this looks like is kind of multifaceted. I think we need to be doing a lot more around prevention with our children and our youth. I think they need to learn about these conditions and the pitfalls of substances from an early age. They'll make their own decisions, of course, but it's important for them to know about about the dangers that are presented with the use of these drugs and with and with the use of alcohol. And by the way, marijuana, big one for the kids. So that's one piece of it. But then I don't have a problem with the term harm reduction, but I would define it differently. I would say that harm reduction is the prevention, the education. Naloxone is very important. Um, but also, I see treatment as harm reduction. I think people should be given the opportunity to choose where they want to do that, what kind of treatment they want, what they think will work best for them. I have found over the course of my time working with folks, people usually come in with they got a pretty sure idea of what they want to do and don't want to do.
Yeah.
And treatment providers, in my experience, we generally respect that and we try to work with
Yes.
these folks. And
Yes.
so I think that's the messaging that needs to be out there. There are lots of evidence-based treatments. They range from everything from medications to social supports to different types of therapies to employment training and help with employment and housing. All of those things are part of treatment programs. I don't think most people know that. So I also think that it's very important for communities to offer those supports to people that are recovering as well. And I think there are ways to do that where people know that they can become part of their community again and be accepted.
That's
Um,
great. Yes.
yes, and so I think that going forward, really, what I hope will happen is that we tell people, um, no, using these drugs in an ongoing way while you think about trying treatment when your brain isn't working right. No, that's not good. That's not what's going to be good for you, what's going to be healthy for you, and what's going to help you. And instead, we make treatment um, more in, uh, more inviting in some ways. What I mean by that, extended hours, transportation if it's needed,
Yes.
childcare if it's needed. Those things are still difficult to get into programs. Not impossible, but difficult. But I think as treatment providers, we want to work towards those things. But at the same time, we want the public to know that treatment is harm reduction. And that's how we're going to save lives.
Wow. Yeah, that's a really good message. This conversation is it I know it's done well for me, so I know the folks who listened into this are going to really find some good nuggets in here. I'll tell you what we'll do. We'll make sure that all of the links that you referenced make their way into the comment section, so that the folks can kind of explore those in itself. And I do just want to say thank you for all of the work that you've done. First of all, thank you for helping us. When we first met years ago, all of the stuff that our program is now was just kind of a theory. And just through a couple conversations, you really helped us wrestle with how we were going to transform into something that we've seen us become a lot more effective from those changes and pivots that we made. So thank you for that. And then your work at the highest level that we know, thank you so much for that as well.
Well, thank you for inviting me because I think these kinds of podcasts are really important. You'll reach people that probably haven't heard these kinds of messages before.
Yeah.
So good for you. And I wish you guys continued success. And I will get to North Carolina one of these days and I will let you
S
know.
Don't forget, we're the best of 6 beaches right here. So if I have to emotionally headlock you with anything, there's beautiful oceans that you want to visit. You wanna be
I
here.
do.
Come see what some of your handiwork has helped create, and that would be great. Yeah. So for all of you who don't know, we'll put the link to all of these descriptions today that we described, and then we'll also put a little bit more details about Dr. McCance-Katz, who's been so gracious to give us her time today. We thank you for joining us. Another episode behind the Citgo, and we'll see you next time.